that in our countries, the most of the people so far who have been affected have been younger people rather than older people. The majority of people, for example, affected in Kenya are under 50, certainly under 60. But if you look at the data from the Western world, from the Far Eastern world, from the United States, it's the elderly who are getting affected more than the younger people. And it may be that if this epidemic spreads to the rural areas in a sizable manner, it may be that the same will be replicated here and our elderly could get affected. And one of the ways that the government has tried to mitigate this spread is to limit movement out of urban centers in Kenya. So we have a group of people who already have many problems, and then we have this new condition that they are vulnerable to. And really, I would say that the key word for this problem facing people living with dementia is vulnerability. They are vulnerable to the virus. They're vulnerable to the effects of the virus on themselves, on their families, on their societies, on the economy of the country. Really, they're vulnerable in every which way. So let's look at this in a bit more detail. How is COVID affecting people living with dementia throughout the world and in our setup as well? So obviously there is a direct health impact. So somebody may have dementia and they get COVID-19 disease. They could get very ill because of their age, because elderly people often have comorbidities. So they may have high blood pressure, diabetes, their lungs may not be as good. They may have cooked on a cooking stove, for example, for many, many years, causing damage to their lungs. And because their lungs are not the best, they are more vulnerable to the pneumonia that this virus causes. And so they would be more likely to end up in hospital on oxygen and in the most severe cases on intensive care units. And obviously in that situation, they are extremely vulnerable and could even not make it. In addition to that, they're vulnerable because the healthcare systems in our countries are impacted by this disease. Now, we haven't seen that as yet as much in Kenya, but if you look at certain places within the country, for example, if you look at an example would be the coast in Mombasa. I mean, the entire Lady Greek Maternity Hospital has had to be, or part of the Coast Province General Hospital has had to be converted into the COVID wing. And they've got, lots of patients there. And then a separate field hospital has been set up at the Technical University of Mombasa. So you can see that there is an impact even in our setting where we have just over 2,000 patients who have had a diagnosis of COVID-19. If you look at the countries where there are thousands and hundreds and thousands and over 1 million cases, like in the US, the impact is massive. In addition to that, because this virus has caused countries to clamp down with lockdowns, with various measures to prevent its spread and to prevent the health systems becoming overwhelmed by the massive numbers of people getting very sick and coming to hospital. There's a huge socioeconomic impact. The economies have ground to a halt. They are contracting. People have lost jobs. There are no incomes. People are going hungry. Some people have become homeless. Add to that, in our situation, the effects of the floods, which have left, I believe, more than 100,000 people homeless in Western Kenya, in parts of the coast and in parts of northern Kenya, the locust nightmare, Kenya's endemic corruption. I mean, if you add everything plus the virus, we're in big trouble. So this virus has had an impact on people living with dementia. People with dementia have an increased risk of getting this virus because of their age, because of their comorbidities. And there's been a recent paper which is not to be taken completely literally, but there is a recent paper suggesting that because people with Alzheimer's disease, especially in Western studies, have the ApoE4 gene positivity at a greater number, and that gene has now been associated in some studies with an increased risk of the virus. So it may be that that's part of the reason why people living with Alzheimer's disease, for example, have a higher risk of getting this problem. But in addition to that, they also have a higher risk of dying from this problem, again, because of age, comorbidities, and also because many people living with dementia would at some point have told families that, look, if I get very sick, I don't want to go to ICU, I don't want to be ventilated, I don't want dialysis. And some people often leave documents, what are called living wills, that also give kind of direction in that regard. In addition to that, people in many circumstances where resources are strained, if you have 30 patients who require an ICU bed and you have only 10, you have to make decisions. Who is going to get that ICU bed? Who is going to get that ventilator? And people who are elderly and have a lower chance of having a productive life ahead of them may sometimes not receive that kind of care simply because there isn't enough resource available. And that's a sad part of life. If you look at how the epidemic ran through in Southern Europe, what's happening in the United Kingdom, and in many other countries throughout the world. In addition to that, there's the impact that this is having on diagnosis and treatment of dementia. So because resources are all being diverted to COVID management, there's the normal kind of clinics, the normal services that are available for people living with dementia have been cut back. So for example, in many countries now, you cannot now run the routine clinics. And even in Kenya for a bit, they stopped. Though there is now a move to try and revive basic services again. To add to that, the social isolation and the lockdowns mean that it's not going to be easy to get people. So for example, I have had patients whom I've had to talk to on the phone when they are out of Nairobi, because it's just not possible for them to come to Nairobi easily. They have to get their special permission. Somebody has to go to pick them up. There's all the issue of roadblocks and harassment. So it does make life difficult for people living with dementia to get care. And to get care in another way as well. So if they have carers coming into their homes, for example, they may have difficulty getting there. The carers could carry the disease with them, and as you saw in the UK, in Europe, and in many other places, care homes, especially where institutionalized care homes, where people with dementia are often cared for, especially as the disease advances. In many of these countries, we have less of that here, though it's beginning here as well. These people, lots of them got infected and lots of them died. And indeed, they are not even yet completely part of the statistics in the UK, for example. So UK's deaths stand at 39,000, but some of the deaths in the care homes are not yet counted. So we have, we'll probably have a higher death toll. The way society has responded to COVID-19, as I said, has isolated people. People who are already living with dementia, with isolation, with loneliness, now are even more lonely and more isolated. And unlike you and me, who can Zoom or FaceTime or WhatsApp video or Skype, these people who are our parents and our uncles and aunts and our relatives and our friends and our teachers and our people who have done a lot for us, we cannot reach out to them, and they cannot reach out to us as well, simply because they're not able to fit into modern communication tools. We've talked about carers and caregivers, and the fact that they may bring disease to these people living with dementia, but there is also a toll that is on them. So people like caregivers, doctors who are working with people living with dementia, nurses, psychologists, there's a toll this disease is taking on them in its own right, and also in this whole care process, which is worsened in this particular situation. And so everybody's mental health, the patients, the carers, the support services, everybody's mental health can be potentially affected. One other issue that we don't think about sometimes is the whole issue of research. So there's been a lot of research going on regarding dementia, but unfortunately, at the moment, much of that research will have had to take a backseat. And what that means is that over time, the whole the whole research output, which will inform care of our patients and some of us who may end up with dementia, is going to be delayed. In all these changes and all these challenges that we face, what can we do? What can we do to help? What are some of the challenges and the things that we can do to help? So simple things like isolation, staying at home, not mixing with other people, what we call social distancing, which I don't like that word. I think it's more of so physical distancing that we need to do rather than social distancing. Very difficult for elderly people especially with living with dementia. They want to be touched, they're tactile, they feel like they need their grandchildren around them, and yet we are depriving them of that space and that need. Difficult questions. Ask them to wash hands. How many of us remember to wash hands? How many of us have left homes without their masks? Imagine a person whose memory is challenged. They will forget to wash hands. They will forget to use the hand sanitizer. They will forget to wear the mask. And if they come out walking on the streets of Nairobi without a mask, they'd be nabbed by a policeman and probably thrown into a cell, or a bribe extracted from them, or beaten up. It's a sad reality, yeah? And so really what the kind of work that Elizabeth and everybody else here is doing to advocate for these people is such an important aspect of the whole body of work that goes into helping these people. Getting carers, if a carer comes home, getting temperatures checked, they themselves washing hands, using a hand sanitizer, wearing a mask. These are some mitigating measures against infection transmission. Looking after patients' mental health and also the mental health of the caregivers is important. And there are various measures, some of them online, that can be taken. Making sure that there is a routine that everybody follows and that routine is not changed as much as possible is really important. Making sure the medications are refilled. They have some follow-up plan, even if it's by telephone or video consult rather than by a physical meeting. Making sure that they are on a regular exercise program. I think all these are important measures to keep things going during this difficult and challenging time. I think the one thing I would say, a routine is really, really important, really important. I want to give you an example of a situation that happened in one town in Kenya. I have a patient who I look after who has a small brain tumor causing balance problems. She lives with her husband. They don't have any children. The husband is dementing. She got COVID-19. She was picked up by the county health authorities. So first she went to a health facility with symptoms and she had a test done. And once she was found to be COVID positive, the health facility dumped her back at home. So here she was at home with her husband, whom she could have transmitted this infection to. And then the county health authorities, because all positive results are reported to the government, the county health authorities came and picked her up and put her in isolation at a government-run isolation facility. She has special needs. Her sister is a doctor. So her sister managed to get her out of there and put her in a private hospital where she had somewhat better care. She's better. Have been picked up by the county authorities and put in isolation. It would have been a disaster. Thankfully, it didn't happen, but it has happened to many people. And if one has dementia and one from an environment, it really creates a lot of problems. People become more agitated and difficult to manage. And it really creates a lot of difficulty for everybody, the patient and the people around them. And this kind of scenario is probably being replicated throughout the country. It's just that we are not hearing much of it. So I think we do have a problem and we need to address it. And I hope that this introductory kind of talk by me can help us think about some of the issues and challenges that we could face or we do face. And I'm happy to discuss them in the question and answer session. I hope this talk has been useful. I purposely didn't do slides because I find slides are very helpful in certain situations, but sometimes just talking face to face is quite helpful. And I think there's a bit of Zoom fatigue now. Thank you very much.
Thank you very much, Dr. Hooker, for that wonderful talk and for giving such wonderful insight. Just for anyone who was late, I just want to recap on what Dr. Hooker talked about, some of the effects of COVID on people with dementia. There's been loneliness. Research on dementia has had to take a backseat. There's been harassment of people with cognitive impairments. If they go outside without a mask or whatever, they will be harassed by police. And also the mental health of the caregivers who have been isolated more now. And he's also mentioned the really good importance of having a routine for caregiving for the people with dementia. So I'll first ask the question by Philippa, who wants to know more about Lewy body dementia. And Philippa, do you want to ask that question yourself?
No, I mean, I have a loved one who's just been diagnosed with Lewy body dementia, and I know I can go and read up about it, but if I can get a quick tutorial on how it, and for, I just want to understand a little bit more about it. I know she's been having hallucinations, and yeah. So I'm just, and how we care for her. There are special things that we need to think about because of her situation.
Okay.
Can I just add, I live in Cape Town, she's in Nairobi, the rest of the family is in Uganda. So it's a complex situation, but, we manage somehow, yeah. She's with her husband, so yeah, it's not so bad.
Okay. So Lewy body dementia is one of the types of dementia, one of the common types of dementia, not as common as Alzheimer's disease, but probably in different studies, the second or third most common cause of dementia. And it's characterized by a progressive, impairment of judgment, memory, planning skills, and characteristically by fluctuating levels of attention with often quite marked visual hallucinations. So they see things, they describe them. They may be people or animals or other things which are not there. And in addition to that, many people with this problem will, indeed, most of the people with this problem will develop some motor impairment, meaning that their walking will be affected and their movement will be affected. And generally it becomes slower, they become stiffer, and sometimes they can shake rather like a person with Parkinson's disease. And indeed, the pathology, meaning the underlying problem with the brain cells, is very similar to what happens in Parkinson's disease, except that the location is somewhat different. With the dementia patients having more of it in the top parts of the brain, and the Parkinson's patients having more of it in the kind of in the deep parts of the brain where. But there is a continuum, and indeed people with Parkinson's disease, many of them will eventually develop dementia, and most people with dementia at Lewy bodies will develop some Parkinsonian features. And so this condition is a progressive condition. There's a progressive loss of brain cells, and therefore progressive, impairment in terms of difficulty managing, and in terms of diagnosis, there are standard cognitive examinations and physical examination that helps one make a diagnosis, which I'm sure your doctor has gone through. And then one often does a scan to make sure there's no other problem. And in certain situations, doing a PET scan can be helpful to see a characteristic pattern of blood flow, blood glucose utilization, brain blood flow, brain glucose utilization that can help support the diagnosis of dementia at Lewy bodies. In this situation, I think in terms of management, the most important thing in terms of medicines, because there are other aspects of management that I think will take a long time to discuss, but in terms of medication, there are drugs called cholinesterase inhibitors, which are used for people with Alzheimer's disease, but actually work even better in people with dementia Lewy bodies. So they're very much worth trying, and the drugs like rivastigmine or donepezil should be tried. And if they are tolerated well, they often help these patients much more even than in the case of people living with Alzheimer's disease. And secondly, the drugs to avoid. As much as is humanly possible, one tries to avoid a group of drugs called neuroleptics or antipsychotics because they would worsen the movement problem and can tip a person into becoming overtly Parkinsonian. So that in terms of treatment, that would be the main thing. As time goes, obviously this condition progresses, and then one has to support their care as much as one can. I hope I've kind of summarized an approach to dementia Lewy bodies. I hope that's helpful.
Yes. Yeah, no, thank you. It gives me a perspective, and
There's some websites you can look up. I'm sure you probably have already. So the Lewy body disease web, associations in different countries, including in the UK. There might be one in South Africa. I'm not sure.
I will look
And also in the US, Canada, Australia. So you could look up their websites, and that might help you as well.
Okay, thank you.
Thank you. The next person with a question is Dr. Muthoni. You can unmute yourself, Dr. Muthoni, and just ask the question.
Thank you very much, Dr. Hooker. I'm very curious on dementia and diagnosis in our country. And my questions are maybe three, and they're around diagnosis of dementia. I would like to know roughly how long does it take to make a diagnosis of dementia, including typing it in that what type of dementia is it? What is the role of CSF in making a diagnosis for dementia? How available and how affordable are PET scans for diagnosis? And last but not least, what do we need to do as a country to make a diagnosis of dementia easy and probably faster and more accurate, where and if possible?
Okay, thank you very much for your great questions. I'll start by talking about how one would approach a diagnosis of dementia. Let me just say this, that the diagnosis of dementia is clinical. And it's the best way to make a diagnosis is to have a clinical encounter where the patient and their loved ones, family, carers, they come in together. And then there is an interview with the patient. We talk to the patient, we talk to the carer, of carers and family, and we put together that information together with a cognitive assessment and a physical examination. And all that would generally take me about 1.5 to 2 hours on average. Yeah, so it is a time-consuming process. It's not something that I can do in 5 minutes or 15 minutes. So you may know as soon as the patient walks in that this is dementia, but to go through the process exhaustively, it would take about 1.5 to 2 hours. So it needs a good amount of clinic time. And really, that is the most important part of the diagnostics. Everything else is supportive. So at the minimum, what is recommended is getting an MRI scan of the brain or a CT scan, basically to exclude other things like, tumors or infections or other problems, an EEG if it's possible, and some laboratory tests, including in our setup, in many patients, an HIV test, because HIV disease is a known cause of dementia, and it's a potentially reversible cause of dementia. If we were to look at these at clinic time, obviously it gets charged by different people at different rates, depending on how much time they take. Yeah, but in terms of costs of evaluation, a scan and an EEG and blood test, depending on where one does them, I suppose in the private sector, the cost would be anything between 30 and how extensively one does the testing in terms of blood tests and all, I would suspect it would be something between 30 to 80,000 shillings. That's roughly the cost. Does one need to do a CSF? Now, CSF has some value in making a diagnosis. So there is a one to exclude infections and things like that. But also because there's a ratio of certain proteins in CSF. CSF is the fluid that one gets from the back by putting a needle into the low back, tapping fluid that bathes the brain, the spinal cord, and the nerves as they exit. This fluid helps us to, we can take a sample of this fluid safely, and testing it for certain proteins, the ratio of certain proteins, the two proteins are beta amyloid and tau, can help guide whether this is Alzheimer's disease or it's something else. But you can imagine that people with dementia don't take very kindly to having their backs tapped. People with early dementia would be quite fine, but with later dementia, find it very difficult to cooperate for this test, and so it's not something that we do all the time, but we do it certainly in young onset patients because we want to exclude other things, and in situations where we want to make a clear diagnosis of, say, Alzheimer's disease, but we don't have access to PET scans. So CSF does have a role, but it's not always done. And obviously it adds to the cost. I suspect the whole CSF examination, like just doing the ratio, costs about 40,000, and doing the whole exam would probably cost another 40 to 60,000. So that adds almost 100,000 shillings to the cost of evaluation. Now, PET scans, we have only one running PET scanner in Kenya at the moment, and that's at the Aga Khan University Hospital, Nairobi. A whole body PET scan costs 70,000. Aga Khan has just about a month or so back agreed to price a brain-only PET scan at 45,000. So that's a significant reduction. So you actually pay less. The unfortunate bit is the NHIF, which used to cover PET scans for indications other than cancer, they did do a couple of PET scans for our patients. They've stopped covering them. So we no longer have the NHIF cover for brain PET scans for patients with dementia. But so it would cost a brain scan, PET scan would cost about 45,000 shillings. So then and is it useful to do it? The answer is it's icing on the cake. It really, most of these other tests that we're talking about, they are not absolutely essential in making a diagnosis of dementia. And indeed, one can trim down a lot of testing and still be able to successfully make a diagnosis of dementia. The tests are useful because you don't want to miss other things. You don't want to miss treatable things. The last question that you had is, how can we facilitate a pathway for making diagnosis? And I think the answer is I think you are in such a great position to do that, because you had that section, and you can actually facilitate a national program both in the private and the public sectors, which there's a clear clinical pathway, a guideline for making diagnosis, which is simple, which uses simple tools, which is relatively inexpensive, and thankfully now CT scans and MRIs are covered by NHIF, so that helps. That takes a big part of the cost out of the equation. So I think having a clinical pathway that is approved by the ministry and that is rolled out across the health system, is perhaps as part of the universal healthcare program, would be the way to go, I believe. Yeah. Thank you so much.
Thank you. I'm going to ask Gladys to ask her question. And I haven't muted her. Lost her to unmute or something. Gladys?
Can you hear me?
Yes.
Okay, good afternoon. Okay, my name is Gladys, and one thing I want to point out about some challenges that us as caregivers go through. When we talk about dementia, mostly even with our speakers, they mainly talk about the elderly. I'm taking care of my husband, who was actually diagnosed at around 45, so he's fairly young. And it becomes very difficult, and especially at this time, for people to understand what is really wrong with him, because he looks young, he doesn't look like physically he has any condition. And when we talk about even going out, he cannot wear a mask because he really is at the stage where he cannot understand why he has to wear the mask. So even going out with him, even for medication, it becomes such a challenge. With the caregivers, you have one who comes daily, and now they cannot come because, of course, of the COVID. And so it is like now the whole thing is entirely on me. And then, okay, since 2015, what I would say is that the diagnosis took long to be found. Like, we started noticing the forgetfulness at around 2012. The diagnosis was made in 2015. And my question to the doctor is, because we've really taken drugs, and at times I really wonder whether they really have to take these drugs that they've been taking, because there are times they don't take them, there are no changes. So is there a time or a point where during the dementia, mine has Alzheimer's, the dementia journey where the drugs are normally withdrawn, or do they have to take them for the rest of their lives? Thank you.
Thank you. So I really empathize with your journey. I did talk about the elderly, but because dementia is commonly a problem of the elderly, but uncommonly young people do get affected. Younger people get affected, and it's uncommon for people in their 40s to get dementia. But it does happen sometimes. We've all seen patients who started off in their 40s and certainly in their 50s and 60s getting dementia. So, and obviously when it hits a younger person, it's that much more difficult because they're at really often the most productive phase of their lives and their families' lives. As far as diagnosis is concerned, I mean, the delay that you experienced in in your husband's diagnosis happens also with the elderly, and in many cases the diagnosis is delayed partly because initially families may not register that there is a problem. They may register there's something odd, but not that there is a problem, a real problem. And secondly, because even when one seeks medical help, sometimes many of us are not very familiar with dementia, and many of us as medical workers could do with a better education in the whole field of cognitive neurology, and so when they eventually do get help from a person who recognizes what this is, some time has passed on. As far as diagnosis is concerned, I mean, you already have a diagnosis, but I've outlined a pathway towards diagnosis in the response to my previous question, and that is what would be often followed. I think your main question is about treatment. We use medicines that have a relatively small effect on these patients' outcomes in terms of what happens to their memories and their brain functions. So for example, in Alzheimer's disease, we use these drugs called cholinesterase inhibitors, which which block an enzyme that breaks down acetylcholine. Acetylcholine is a chemical messenger which helps brain cells talk to each other. So brain cells which are there and which are connected, because brain cells are becoming less, their connections are becoming less. Those that are there and that are connected, they can talk to each other better. And in some people, that results in a significant improvement in their memory in their behavior, and helps to keep things going that way for some time, usually for a period of months, maybe for a year or two. And then they continue to decline. Now, the underlying process in the brain is actually declining anyway. All you're doing is helping brain cells to talk to each other better for a bit. Yeah. And so there may be an outward manifestation of improvement. But now in countries where the people then end up in care homes, rather than being cared at their own homes, but in care homes, external facilities, what happens is governments and funding agencies are interested in keeping people at home living independently rather than in the care homes, because in the care homes, the cost of care is much higher. And in many of these situations, the cost of care is being picked up by the government or by some sort of funding agency. So, and these medicines have been shown to delay the time it takes for a person to reach institutionalized care. And so that way saving costs. So governments and insurance companies are willing to pay for the medicine because of that saving in cost. Then the question is, which is really your main question, is do they have to continue taking that? If it is that particular type of medicine that he is taking, does one have to continue taking the medicine? And the answer to that question came in a study in the UK, where they looked at people who, after say 2 years or 3 years, they were progressing, they were getting worse, and a decision was made to stop the medicines. And unfortunately, in the arm of that study that stopped medicines, they deteriorated faster than the arm that continued the medicines. So the current guidance is that except if the medicine is causing side effects, it's better to continue, because if one stops, they may go down faster. Okay? But there are caveats to that. Like, one is side effects. If somebody is having side effects, there's no point taking the medicine. Okay. Secondly, if they're refusing to take the medicine and they don't want the medicine, and it's becoming a challenge to give it to them, then I think it's perfectly acceptable to stop at that point. Yeah. So I think that would be my response to your question. There are obviously other medicines that are used for dementia, and these are usually medicines to modify behavior and some of the more mental health symptoms that patients get. You know, the agitation, some people can get quite aggressive and even violent. Those kinds of medicine obviously are used as needed, and then the use would be dependent on need. Okay.
Thank you.
Yeah. Okay.
Yes. Gladys, does that answer your question? Yes, okay, cool. Thank you. I'll just give Elizabeth the chance to ask her question now. Elizabeth.
Okay, Dr. Hooker, thank you for the presentation. One of the things you mentioned was about the living will. Now, in our case, especially in Africa, most of the people, by the time they go to hospital, they are, of course, they're older persons, one. Number two, in Africa, we don't talk about writing wills because a lot of people are scared about that. Of course, it is changing now, but I'm just wondering, in cases where, and it would be most often than not, in cases where somebody has not done their living will and they have not said, don't resuscitate me, for example, when I come to hospital and I go, maybe the first time. And then, so what do you do in such cases? Because a lot of times, I know families, we want to hold on to our loved ones. We don't want to make decisions, and yet sometimes you're at a position, and then also within the family, there'll be that tension because why are you deciding this? what if we could try something else, maybe to make them live longer? So in such cases, I'm just asking just a general question. What would happen in such cases?
Yeah, so this is a situation we see quite often, and thank you very much for bringing it up. So the first thing I would say is I would encourage all of us, whether we are well or we are not well, to write a will. I don't know if you read the newspapers, but have you seen how many billionaires' families are in court over their estates? And some of that is in spite of a will. The will's being contested. And, I mean, it's actually a mercy sometimes not to have billions, because if you see what goes on in those court cases, I mean, they're quite melodramatic, yeah. And really, we have a situation where many of us, we die without wills, and then our families are left, in distress. People con them. Lawyers have been involved in, certain situations. I'm sure you must have read and heard about them. And I've certainly had situations where I've had to extricate patients of mine from really difficult situations. So lawyers can be good lawyers can be very helpful. Yeah. One, to set the will straight. And as far as writing a will is concerned and writing a living will is concerned, actually they're downloadable documents on the net, very good ones. I think from the Alzheimer's Society websites from other countries, and one can download and modify a document, so it's pretty easy to do, and you don't necessarily need a lawyer to do that. Yeah. Obviously, if they're complex, estates, then legal advice can be useful. Yeah. But I mean, when somebody has a limited amount of money or property, I think it's pretty easy to do. Yeah. Okay. So I would really encourage that. The second issue is where there is no living will or advance directive, either written or verbal. Because sometimes people may not have written, but somebody may have said that, look, I don't want this done. Then it's very easy, especially if, so I often ask if they have, I like in patients with dementia whom I see when I make a diagnosis, usually, if not in the first meeting, then certainly in the second meeting, I would bring up the issue of, getting a will sorted out and getting advance directives done. Yeah. It doesn't always get done. My estimate is it probably gets done in about 10 to 20% of cases. People don't like discussing it further, but I do bring it up. Yeah, okay. It's very helpful when it gets done. Now, where there is no such directive, then I think it's a matter of judgment for the next of kin, and for the medical people. So there needs to be good medical advice. Look, if somebody has dementia and they've got a bad infection and they are succumbing to that infection, taking them to ICU and spending another 5 million shillings and then dying is not going to be helpful to the family when the family's estate is limited to 5 million shillings. As an example, yeah, you've wiped out the entire estate, yeah, or you've put the family into debt and the person is still not there. See, families do find that difficult to accept, and they often do go into debt and wipe off their estates. But sincerely, we need to have a change of mindset. Yeah. Because, I see so many families struggle, It really, really hurts me. Like, I'll give you an example. I have at the moment a 75-year-old gentleman in ICU whose 2 daughters cannot agree on what needs to be done. He needs a care plan that takes him home. He shouldn't be in ICU for longer than a few days. But because that whole decision-making process is dragging on, it's just going on, and it's costing them a lot of money. You know, being in ICU in some of the private hospitals in this country, you're looking at hundreds of thousands of shillings every day. It's a lot of money. Yeah. You know, so I think judgment comes in. Now, in the specific situation of COVID, you know, if somebody has their heart stops or their breathing stops, which breathing would be unusual because they would be on a machine in ICU, but if their heart stops, by the time the staff can access the person to resuscitate, because of wearing all the personal protective equipment, it would take another 10, 15 minutes. They would not be resuscitable. So in practice, patients who get COVID and arrest, meaning their heart stops, will effectively not be resuscitated. Yeah. Yeah. And if they have dementia and they have this, I mean, seriously, I think sometimes it's merciful. Sometimes really we have to be humane. These people are people, they're human beings, they're suffering. And sometimes it's merciful to let go rather than to cling on and take them through, you know, futile medical interventions. One thing we must remember about modern medicine is what we can do is not what we should do. Yeah. I hope that helps answer your question. Thank you.
It does. Thank you. Thank you.
Thank you. We are almost out of time, and I don't see any other question, but I see Philippa raise her hand.
Yeah. It's a quick comment, really, linking to that question. Sorry, because I remember when my father was 70, he didn't have dementia, but I remember very helpful advice that was given to me that might be helpful to give families who have dementia. And I was talking to our reverend, and he said to me, you know, Philippa, your parents are getting older now, and they might live for another 20 years, they might not, but it is helpful for you now to start preparing for their passing. And one of the things you need to do, because I think many of us come from very spiritual families, to pray about it, to release your parents to God. And he advised me to almost do a life timeline just for myself and look at the things I'm grateful for to my parents. What are the questions I'd like to ask them? Where do I want to say sorry to them? Where do I want to say thank you to them? And I ended up writing a letter to them to say thank you and all sorts of things. And to just go through that angst of I'm letting go of my parents, but it's not that I'm wanting them to die. My dad lived for another 7, 8 years, my mom even more. But when it came to the time that my father died, I was at peace. I had made peace with letting him go. It wasn't that I wanted him to die. The pain was still very great, but there was a peace that I felt. He died in 2006. In 2000, he had been on the brink of death. And at that point, I was not ready to let him go. But after that counsel and after me doing the work on myself, when the time came for him to go, I had made peace with the fact. And he had spoken to us and said, I'm 70 and from now on, I'm living on borrowed time, the kind of man that he was. We laughed about it. But I think it's really important in circles like this and with carers to have those kinds of conversations, because death and life live side by side all the time. It's hard, but we must do the work and we must allow our parents to go in peace, because sometimes they linger on because they think we won't survive without them. That's the other thing, you know. You see someone is ready to go, but they're not going because they sense the family is in conflict and they stay for longer. Just wanted to say that from personal experience.
And can I add that the families that we deal with who are spiritually inclined and who have a, great faith, it's much easier for both the patients and the families to handle this journey, this part of our journey, because we all have to go through this journey. It's not unique to them or us or anybody. All of us have to go through it. Thank you very much for that.
Yeah, thank you. Just to add on that, we had a discussion about advanced care planning and how much it's just saving time for doctors who have so much work to do. And I'll tell you for sure that Dr. Hooker has so many people to give his services to who need him. We have very few neurologists in Kenya. And sometimes, and I feel strongly that it's time we develop that capacity whereby Dr. Hooker is not the one who gives advice on, on advanced care planning, that we develop capacity so that like he can continue doing his work while we do other things. None of my rotations here in at St. James Hospital in Dublin, how diagnosis is made, the neurologist will make the diagnosis. There'll be a social worker and there'll be a psychologist, and they'll talk about that whole spectrum of the changes that will happen in someone's life after a diagnosis, from when to plan to go to a care home, from advanced care planning for health, from the legal part of it. And it's really useful. And it just makes you see the situation and how the complexity of dementia and how it affects our families. So I just want to thank Dr. Hooker for such a wonderful presentation and for taking time to answer our questions. I think we are out of time, but if you have any more questions, I think you can direct them to Elizabeth, who will direct them to Dr. Hooker. And thank you for coming for this meeting, and I hope everyone found it useful. So thank you so much. And I wish you all the best. Yeah, bye.
Thank you. Bye. Thank you.
Bye.
Thank you. Bye.